Let's jump straight into an integrative mixed block review targeting advanced clinical reasoning. We're focusing strictly on high-yield mechanisms, absolute diagnostic boundaries, and management traps to ensure perfect execution in your clinical decision-making. No fluff, just the clinical material you need for a top-tier score.
Our first critical diagnostic boundary is in ascitic fluid analytics. The absolute threshold you must recognize is a serum ascites albumin gradient, or SAG, of exactly 1.1 grams per deciliter.
The mathematical derivation is straightforward. It's simply your serum albumin minus your site's albumin. But the physiological implication of this calculation is absolute. This gradient fundamentally differentiates hydrostatic from non-hydrostatic intra-abdominal forces. A gradient of 1.1 or greater definitively confirms that portal hypertension is driving the fluid shift.
Notice the absolute divergence in the differential diagnosis across that 1.1 boundary. Values equal to or above this line dictate targeted vascular or hepatic management, isolating cirrhosis, right-sided heart failure, or Biliary syndrome. Conversely, a SAG strictly below 1.1 mandates a search for local peritoneal inflammation or decreased oncotic pressure, isolating etiologies like peritoneal carcinomatosis, tuberculosis, or nephrotic syndrome.
Let's apply this in an integrated assessment. Consider an older patient presenting with new onset ascites. Fluid analysis reveals a SAG of 0.8 grams per deciliter and a definitively negative cytology screen. Your task is to isolate the underlying etiology.
Evaluate these 5 highly competitive choices. You'll notice how the first 3 and the last option heavily bait you toward the most common mechanisms of portal hypertension. This is designed to test your strict adherence to the SAG paradigm in the face of high-noise distractors. Systematically dismantling this requires strict logic. Step 1. The SAAG is 0.8, which definitively rules out portal hypertension. Step 2. Because we've excluded portal hypertension, we must immediately eliminate cirrhosis, right-sided heart failure, and both Biliary and hepatic vein thrombosis. Furthermore, the negative cytology screen rules out peritoneal carcinomatosis. Step 3. We successfully isolate tuberculosis as the sole remaining viable non-portal hypertensive, non-malignant driver of this patient's ascites.
The crucial takeaway here is the absolute divergence in management pathways. A SAG of less than 1.1 completely excludes portal hypertension algorithms. At that point, you're no longer managing hydrostatic pressure, you're hunting for local peritoneal pathology or systemic oncotic collapse.
Next, we establish the strict diagnostic mandate for spontaneous bacterial peritonitis, or SBP. The trigger for intervention is an absolute acidic polymorphonuclear, or PMN, cell count of 250 per cubic millimeter or greater. We must strictly differentiate the infectious and biochemical signatures of SBP against secondary peritonitis. SBP is typically monomicrobial, driven by enteric translocation, and managed medically. Secondary peritonitis, however, is a catastrophic viscous perforation. Its signature is polymicrobial, accompanied by high acidic total protein, often greater than 1 gram per deciliter, and low glucose. This presentation strictly mandates an immediate exploratory laparotomy. Crucially, we must isolate the renal protection rule. Initiating a third-generation cephalosporin like cefotaxime is mandatory, but insufficient on its own. Intravenous albumin must be co-administered. If you fail to give albumin, the splanchnic vasodilation triggered by the infection can precipitate the catastrophic hemodynamic shifts of hepatorenal syndrome, leading directly to acute kidney injury and a rapid clinical decline.
Let's apply this logic. A cirrhotic patient presents with fever, abdominal pain, and an acidic PMN count of 800. However, the gram stain yields both E. coli and bacteroids. You must select the next best step in management. This scenario demands that you recognize the precise biochemical transition from a medical abdomen to a surgical one.
Review these 5 management steps. The medical management options are plausible distractors designed to trap you into continuing standard conservative medical titration for a presumed severe SBB, while the TIPS procedure offers a highly invasive yet decidedly incorrect vascular intervention.
Let's tear down these distractors. The polymicrobial signature of E. coli and Bacteroides completely overrides the patient's cirrhotic history. This is no longer spontaneous bacterial peritonitis, it's secondary peritonitis indicating a perforated viscus. Therefore, medical management with cefotaxime, albumin, or metronidazole is definitively insufficient. TIPS is strictly contraindicated in the presence of an active intra-abdominal infection. The only correct pathway here is emergent surgical exploration to achieve source control.
Finally, we'll focus on oncologic differentiation in the biliary tree. Both pancreatic adenocarcinoma and cholangiocarcinoma can present identically, with painless jaundice, pruritus, and clay-colored stools. The separation relies entirely on clinical and anatomic markers. Pancreatic head tumors frequently present with a palpable, non-tender gallbladder, known as the Courvoisier sign, and massive elevations in CA 1999. Cholangiocarcinoma, conversely, is heavily linked to primary sclerosing cholangitis and ulcerative colitis, localizing strictly to the biliary tree without pancreatic duct dilation.
Looking at the axial CT, we can clearly identify a distinct solid mass in the pancreatic head. This lesion is anatomically positioned to cause distal common bile duct obstruction. That obstruction leads directly to the ductal dilation and the massively distended gallbladder that defines the Courvoisier sign we just discussed. Let's evaluate a third-order presentation. A patient with a history of bloody diarrhea presents with progressive jaundice, weight loss, and intrahepatic biliary strictures. Crucially, imaging confirms the absence of a pancreatic mass. Isolate the exact underlying pathology.
These 5 distinct hepatobiliary etiologies all feature overlapping symptom profiles of jaundice, cholestasis, and weight loss. Isolating the correct answer requires complex integration of the patient's gastrointestinal history with highly specific biliary imaging findings.
We must trace the multi-step diagnostic logic. Step 1. The history of bloody diarrhea strongly indicates inflammatory bowel disease, specifically ulcerative colitis. Step 2. Ulcerative colitis is heavily associated with primary sclerosing cholangitis, or PSC. Step 3. PSC directly causes the intrahepatic biliary strictures seen on imaging and serves as the prime risk factor for malignant transformation into cholangiocarcinoma. Step 4. The explicit lack of a pancreatic mass systematically eliminates pancreatic adenocarcinoma, leaving cholangiocarcinoma as the only definitive diagnosis. This clinical variance reinforces the definitive structural and historical boundaries that separate these related malignancies. Cholangiocarcinoma is an intrinsic ductal pathology associated with chronic inflammation, presenting with strictures rather than the external compression by a pancreatic head mass that creates a Courvoisier sign. To conclude, cholangiocarcinoma is a malignant tumor of the bile ducts, frequently arising in the setting of chronic biliary inflammation and primary sclerosing cholangitis. Master these structural and historical boundaries to execute perfectly on the wards.